and nationally on topics related to neurologic physical therapy practice. Dr. Colón-Semenza is now focused upon determining best strategies to enhance the use of physical activity and physical therapy in the management of Parkinson's disease and other neurodegenerative diseases, specifically in underrepresented groups, which we're going to hear about today. Additionally, she's interested in physical therapy management of mental health conditions, which will tab nicely for some of our participants today as we link pretty strongly to our clinical psychology program. She's also active in the American Physical Therapy Association nationally and locally, and is the chair of the Diversity, Equity, and Inclusion Committee of the APTA Connecticut and the Neurologic Special Interest Group. Thank you so much for taking time to speak with us today, and I'll turn it over to you.
Great. Thank you so much, Dr. Wolf, for the introduction, and really want to thank you and the Pepper Center at Northwestern for this invitation and this opportunity to talk with you all about my research directions and lines. And I'm really looking forward to a fruitful conversation to learn from all of your expertise. So thank you so much. So to start us off, my objectives here today are to really introduce the problem that I've identified within our current healthcare system and that's facing Hispanic individuals that are living with Parkinson's disease. I would like to share my research question, my conceptual model and design to address this problem. And then, as I indicated, to have a discussion about this. More specifically, I'm going to provide my personal context. I do use mixed methods, so want to explicitly share my biases. I'll share a bit about the research background, some preliminary research that has brought me to this Pepper Center project, and then share the research questions, specific aims, my conceptual model, and the research design, and a bit of my timeline for this project, and then end with our questions and discussions. So in terms of my personal context, I don't have any financial disclosures or conflicts of interest, but I do have biases. I've been a physical therapist for over 25 years, working across various practice settings, as Dr. Wolf has indicated. I started off working in central Pennsylvania in an acute rehabilitation facility, as well as working in a level 1 trauma center here in Connecticut at our level 1 trauma center and acute rehabilitation facility in Hartford. And the majority of my experience comes from working at an outpatient physical therapy clinic here at the University of Connecticut, the Naden Rehabilitation Clinic, where I did work primarily with individuals with neurological disorders and had a focus on Parkinson's disease and became a neurologic clinical specialist. During my time there, though, being that our field is so young, there are still so many questions out there that remain unanswered. And so I went back to school recently to obtain my PhD in rehabilitation sciences at Boston University and worked at the Center for Neurorehabilitation there. So regardless of the practice setting that I was in, unfortunately, there was a problem that I encountered, and I don't believe that I'm alone in encountering this problem, is that we would often run into this revolving door problem. And what do I mean by that? So the revolving door problem is that you would have a patient, whether this is an older, frail individual who has debility, or whether it's a person with Parkinson's disease, and let's say they're having issues with their functional mobility, or having difficulty getting up from the couch, or low surfaces, getting in and out of the car, and you have a directed plan of care. You work with that individual for 4, 6, 8 weeks. You build their strength, their motor control, their functional ability, improve their quality of life. Everything's going well. You discharge them out into the great abyss, and then they come back another 4, 6 months later. And then you have to go through this same thing again. You think that you've created the correct discharge plan. However, unfortunately, this revolving door often happens all too many times with our patients. So it caused me to reflect on, okay, what am I doing wrong? And I totally admit guilt that I would often just give out this little piece of paper that you see here. And maybe some of you have received this, or for those of you who are physical therapists, you too have given out this piece of paper. And we somehow imagine that giving someone this little piece of paper is going to motivate them and sustain them for months on end, or potentially even a lifetime of exercise and physical activity. This is not unlike what's often done in the medical community, right? We all know that exercise is critical for our health, wellness, disease prevention. Our doctors are often saying exercise more, right? But maybe that is not the best infrastructure. Maybe that is not the most effective means to have people utilize exercise and physical activity in the management of their health and wellness. And so we'll pause here to ask you all to reflect on, did you exercise today? Did you potentially ride into work today with a friend, colleague, significant other, or do you have a standing date to go to a yoga class tomorrow with some of your friends, colleagues, family members, significant others? When I think about my own experiences with exercise and physical activity, as well as looking at the literature, the social support network is often key to engagement in exercise and physical activity. So to attempt to address this in my clinical practice, we did start an exercise group for people with Parkinson's disease. After they went through that standard course of care with me for that 4, 6, 8 weeks and did experience that progress, were able to now get up from that chair or be able to walk at a faster rate, whatever that goal was, I didn't just discharge them out into the great abyss, but we invited them then to join us for a weekly exercise class that was targeted to their needs, targeted for people with Parkinson's disease, 12:30 every Friday. And I'm happy to say that we actually just celebrated our 10-year anniversary of running this exercise class for people with Parkinson's disease. And guess what? Some of the people who started with me 10 years ago are still in that exercise class coming every Friday afternoon. So these are my biases. This is my background. This helps you to understand where I'm coming from and how I come to this research problem that I'm encountering. So now we'll step back and chat a little bit about the background specific for this topic at hand and this research. So to just center us all on Parkinson's disease, it is the second most common neurodegenerative disease, second only to Alzheimer's disease. We do know that it is a deficit in the dopamine producing cells, right, in the basal ganglia and the substantia nigra. It was historically known as the shaking palsy, right, because the tremor, the rigidity, the akinesia or bradykinesia, that slowness of movement and postural instability are all components, the cardinal signs and symptoms of Parkinson's disease. And so it was previously thought, well, it's a movement disorder, right? What can exercise really do for a movement disorder? And when I was in PT school, there really wasn't much talked about in the utilization of exercise in the management of Parkinson's disease. But since then, since the early 2000s, there's really been this surge in the research related to exercise and physical activity in the management of Parkinson's disease. So you see this really sharp incline and trend when I did a little query about exercise in Parkinson's disease, what's out there. So right over 500 publications were happening in 2020. So why is the surge in the literature and attention to exercise in Parkinson's disease? Because the news is really exciting and really great. It's that when we look at animal models of Parkinson's disease, exercise has a neuroprotective effect in reducing risk for Parkinson's disease, but even has a potential for recovery or neuroplasticity. We see the same thing true when we bring this to clinical models and human models, right? We see that the dopamine receptors are more receptive to dopamine, that there's protection of the dopamine receptors. We see that there are neuroplastic changes with evidence of increased levels of BDNF or brain-derived neurotrophic factor. So we're seeing in animal models and in clinical models that there is evidence from a neurobiological standpoint of improvements. But what does this mean to the lives of people with Parkinson's disease? Well, there are actually symptomatic benefits that patients are reporting, that there are less symptoms, that they have better quality of life, better movement, maintaining independence when adequately using exercise at an appropriate dose. And it is often this high intensity aerobic exercise that is a critical component to appropriately using exercise in the management of Parkinson's disease. So much so now that really exercise, there's this universal prescription for Parkinson's disease. So so you get diagnosed with Parkinson's disease and you don't just receive your dopamine replacement medication. Really best practice is at diagnosis, you are also getting the appropriate prescription for exercise in the management of your disease process. So you're thinking, well, great, this is so exciting, right? Exercise is neuroprotective, it helps with symptom management. There's even evidence that it might be disease modifying, that it slows down the disease progression. So everyone with Parkinson's disease must be exercising, right? Doctors are prescribing it. And as we all unfortunately know, unfortunately, the levels of physical activity generally remain low for this population, despite the robust evidence of the power that exercise has in disease management. So why is this happening? So some of this might be related to the fact that, we really were paying attention more to the dopamine pathway, which is this red pathway here. This is the nigrostriatal pathway. This is the pathway that modulates movement and motor control and is responsible for those cardinal signs and symptoms of Parkinson's disease. And that's where all the attention and care has been given, is to thinking about the effect of treatment on modulating the motor symptoms. But what we have come to understand and appreciate more recently is that there's a huge non-motor component to this disease process as well. There are dopamine pathways, and this one here in green here that starts off in the midbrain and travels to our nucleus accumbens. This is the mesolimbic pathway, and this pathway is primarily responsible for motivational aspects. So our wanting or approaching goals, our goal-driven behavior is modulated through this pathway. So maybe in the treatment of Parkinson's disease, we shouldn't only be paying attention, right, to these motor symptoms, but also the non-motor symptoms that are really prevalent in this patient population and might have more implications for quality of life. So there has been an investigation to understand, how do all of these components play into whether people are using exercise in the management of their disease? So in this study, they were looking at factors such as age, income, disease severity, as well as some of these behavioral factors to understand what makes someone a regular exerciser or not. And they defined a regular exerciser as individuals who are engaging in moderate to vigorous exercise for over 150 minutes for at least 6 months, right? So they're adhering to those American College of Sports Medicine recommendations to get adequate exercise, and defining those people who are regular exercisers as really doing this and doing this for a sustained period of time. And more so than disease severity or these motor symptoms, self-efficacy was the most strongly correlated with whether or not someone was a regular exerciser. So there's self-efficacy specifically for exercise. So do they have that belief, that confidence in their ability to exercise? And if they did, that higher self-efficacy was related to whether or not they were an exerciser or not. And this fits well with our theories of motivated behavior, right? We know that one of the foundational theories, the social cognitive theory by Dr. Bandura, has self-efficacy at the core. Self-efficacy drives our goals, drives our behavior. And so that if we can potentially focus on self-efficacy, we might see this increase in exercise and physical activity. Similarly, the self-determination theory by Deci and Ryan also has self-efficacy as a core component within that component of competence, right? So if someone believes that they're competent in exercise and physical activity, they have that higher belief in their ability, that confidence in their ability, that will lead to them being an exerciser. In addition, having autonomy or having the ability to choose and make decisions about one's own health, life, exercise, physical activity, that will motivate them, as well as relatedness. Having that social network, feeling like you're belonging to a group, feeling like you have the support that you need to engage in exercise will also lead to that motivated behavior of exercise and physical activity. So I was involved in a study where we were focusing on trying to target self-efficacy in an interventional study that had two groups. The one group was using exercise and physical activity, but the mode of engagement with their exercise and physical activity was using pen and paper. So they had pieces of paper with pictures of exercises similar to what I showed you earlier on, right? That piece of paper. And they had calendars that they used where they would write down when they were exercising and how many steps they would get using just a cheap old pedometer. The mobile health group was engaged in using an app where they received their exercises, they engaged with a physical therapist in a chat function, and they used a Fitbit to gauge their steps. So similar intervention, there was an active control group, but one was using less technology, it was pen and paper. The other one was using this higher technology group. Both groups had a level of accountability though, because the pen and paper group was mailing in their results every month to the research administrators. And so it was more so, I would say, than typical clinical practice after you discharge someone. And this was actually considered a negative trial because there wasn't a significant difference. Everybody got better in terms of their change in steps per day. Everyone became more active with this intervention. And we hypothesized that because this active control group still had that level of accountability and feedback on their goals by interacting with our research team. There did seem to be a differential effect in subgroup analyses of the people who were more sedentary at baseline, who had less steps at baseline. And there seemed to be a stronger effect for mobility-related quality of life in those individuals. But we wanted to learn more about this mobile health technology and what people did or didn't like. And what was a common theme was that everyone loves the chat function. They loved being able to chat with a physical therapist within the app to say, hey, I did my exercises today, or I feel great, or I'm having this problem. And that was actually what they wanted more of. They were able to engage with the therapist, but the therapist wasn't, live immediately reporting back. She would just respond once a week to comments in the chat function. So thinking about this, how can we make it more feasible to give individuals that support that they need? And the physical therapist actually indicated that it often did not require a high level of skill to provide the level of accountability and social support that individuals were often craving. They often just wanted someone to acknowledge, great job, or, oh, you did that, terrific. I see that you're working hard at that. So this brings me to some of my preliminary research. So given what we learned from this previous study, I worked with the group to develop a peer coaching intervention using mobile health technology to support physical activity in people with Parkinson's disease. And this was a small feasibility study where we investigated, will this work? So we did have individuals who were adhering to that 150 minutes of moderate to vigorous physical activity. Those individuals we delineated as our peer coaches, and those individuals who were not yet achieving that 150 minutes, those were considered our peer mentees. Everyone in the group received a Fitbit Zip. I don't believe they even make these anymore, the Zips, but it was a Fitbit and they had access to the Fitbit application. Our peer coaches then underwent peer coach training over a period of about 2 to 3 weeks. And this was done in a hybrid fashion, which some of the information and the didactic learning happened via pre-recorded PowerPoint educational slides, some readings and online links. But then we also did bring individuals in and we did some role playing to help consolidate their learning related to active listening, motivational interviewing, creating SMART goals, as well as deriving action plans and addressing barriers and facilitators to exercise, as well as the basic information about what is Parkinson's disease and how does exercise help. So after undergoing that peer coach training, we then matched up individuals, both a peer coach and a peer mentee, only based on their self-identified gender. Once they were matched up, the peers interacted once a week in a telephone call, and they also interacted via the Fitbit app, where they were able to see each other's accumulated steps and were able to model and create comparison between their achievements and their peers' achievements over that week's time period. So what happened at the end of our 8-week time period? So here you'll see in table A, our average steps per day. The gray boxes are their baseline and the red boxes are after that 8-week time period. And at the group level, we did find that there was a 33% increase in steps per day, with individuals at the group level starting off around 5,000 steps and increasing to about 7,000. And so to give some perspective on this change, the MCID for individuals with a progressive neurological disease is about 700 steps. So they well exceeded that MCID. Similar trend was seen in the active minutes per week, and active minutes is defined as minutes that exceeded 3 metabolic equivalents, which is approximately moderate to vigorous physical activity. And there was a 42% increase at the group level in these active minutes, moving from 199 minutes per week to over 280 minutes per week. So this is good news, right? We were able to increase physical activity. We did in qualitative interviews learn a lot from this version of the study. There was some critique in terms of having a hierarchy that participants indicated they felt like everyone is trying to use exercise and physical activity in the management of Parkinson's disease. So why does there need to be this model of one person being a coach and one person being a mentee? Why can't we all be working towards the achievement of our goals together? So we've taken that in mind as we've moved forward. But another observation was that whether it was this study or whether it was my observations of the participants in our specialty clinic at Boston University's Center for Neurorehabilitation, or whether it was my participants in my exercise class at the University of Connecticut, there was this trend of the participants and the patients were highly educated white males, right? You'll see here that our participants all had greater than college level education, predominantly men, which fits with the demographics of Parkinson's disease. There's a higher prevalence in men. But here we only had one individual in our study who was not white. So there was, in my early learning, this understanding that the demographics of Parkinson's disease was that it had a higher prevalence and incidence in the majority population. However, more recently, we've actually come to understand that no, actually the highest prevalence that's finding among different ethnic groups is that it's highest among Hispanics. And yet, both in my clinical practice and what plays out in the literature is we're not seeing individuals participate in physical therapy, exercise groups, or in the research process. And luckily, there have been some investigations to help us understand, well, what's going on here? Why is this? And so Hispanic perspectives on Parkinson's disease care and research participation shared some themes that they found from interviewing people who are Hispanic and living with Parkinson's disease. And some of the themes that came out was that family involvement in the research process is critical for their involvement, that they want the researchers to be of a similar background, to be able to engage in their preferred language. And there were concerns of financial burden for participating in the research studies. In terms of perspectives that came out of this study, this one I found was fascinating, that only 35% of Hispanic people living with Parkinson's disease indicated that they believed that exercise was important for PD management. So that means 65% of individuals in this study did not think that exercise was important in PD management. And that's after me telling you that potentially, right, what the evidence is telling us is that it's neuroprotective, it's helped for neurorecovery, you're living with less symptoms, better quality of life, and it might even slow down the disease progression. So this is really astounding and upsetting, right, that individuals from this population are not aware of the power of exercise and physical activity in the management of their disease process. And this was confirmed with another study that was done in New York City and looked at Hispanic individuals living with Parkinson's disease at one facility, one hospital in New York City and another hospital in New York City. One was Bellevue, where the predominant patient population is Hispanic, and the other one was NYU, where the predominant patient population is non-Hispanic. And they were looking at beliefs related and management to Parkinson's disease in these two groups. And again, it played out the same, that the Hispanic individuals were less likely to report being exercisers and were less likely to report engaging in physical therapy. So this is disturbing given the power that we know exercise, physical activity, and physical therapy has in the management of Parkinson's disease. So recently, I have conducted focus groups to help really delve deeper, have a better understanding of beliefs, values, and experiences related to exercise in the management of Parkinson's disease in both Hispanic and non-Hispanic individuals. We were able to recruit 10 individuals living with Parkinson's disease who were Hispanic and 15 non-Hispanic individuals, and our sample was pretty similar in terms of their demographics. However, the age was different, significantly different in these two groups, with the Hispanic individuals being significantly younger. So some of the trends and themes that I'm finding cannot solely be attributed to ethnicity and might be attributed to age as well as ethnicity. We had a diversity of participants in that we had 4 Puerto Rican participants, 1 person Mexican and living in Mexico, 2 Mexican Americans, 1 person who was Colombian American, another person from Guatemala, and 1 person who was Hispanic but did not identify their country of origin or background. And so I have a lot of themes here. This is unpublished data, and we're still in our data analysis working on evaluating this qualitative data from these focus groups, but I wanted to share with you some of our preliminary results. And we did use directed content analysis to guide our qualitative data analysis using the social ecological model of health to be able to delineate the individual level factors, interpersonal level factors, and then we condense the community policies and culture into environmental factors. And so the colors here of the text corresponds with the level of the social ecological model. And there were absolutely commonalities that we found between Hispanic individuals and non-Hispanic individuals living with Parkinson's disease in terms of their beliefs, values, and experiences with exercise. And some of those were that, a very common barrier that people talk about is not having enough time, so lack of time, fatigue or the disease symptoms themselves. This was another commonality that was interfering, and the family as a motivator, right? In both groups, individuals would report, my grandchildren keep me so active, I'm playing with them, or I see my grandchildren and they are my motivator for me to get up and exercise and keep moving because I want to be healthy to be able to be with them. But some of the unique findings that we found in the between the 2 groups is that there appeared to be decreased exercise knowledge and less experience with prior experience with exercise in our Hispanic individuals, with less individuals reporting use of organized sports and exercise early on in life or before diagnosis. Whereas there was a high level of knowledge and depth of knowledge, and even depth of knowledge not only about exercise, but of the appropriate prescription of exercise in the management of Parkinson's disease. Another unique finding was that individuals from the Hispanic group often would talk about exercise, wanting exercise to be joyful, for music to be involved, to involve dance, fun. They wanted it to be this joyful experience, whereas in the non-Hispanic individuals, the theme that came out was that exercise was more like a responsibility, it was work, and there was not this same connection with it necessarily having to be a joyful experience. There was also a higher dedication of resources, and individuals often talked about how they used exercise to help them feel empowered in the non-Hispanic individuals. So a unique finding in the Hispanic individuals is that there seemed to be less knowledge about Parkinson's disease within their social networks. So individuals would say that their family members didn't really understand what the symptoms were, what Parkinson's disease even was, whereas that was not a theme that came out in our non-Hispanic groups. And this lack of knowledge about Parkinson's disease led to shame, embarrassment about their symptoms. Individuals would report, oh, if I'm going out to an exercise group, I'm hiding my symptoms because people don't understand what's going on with me. Or even sometimes the exercise instructors, if they were in an exercise group that was for the general public, the exercise instructors themselves would not understand what was going on with them. And so they felt like they had to hide their symptoms. And we did not find this in our non-Hispanic individuals. So to drive home some of these themes, I have some quotes from the individuals in the focus groups, exemplifying the depth of exercise knowledge and perception of engagement with exercise. One non-Hispanic individual stated, I work out 4 or 5 days a week. I take a class on Wednesdays that's specifically designed for people with PD. It's a high intensity workout, including boxing. And the other 4 days of the week, I go to the senior center and I do an hour to a 90-minute workout there using all the equipment that they have. Whereas our Hispanic individual, yes, he recognizes he needs to exercise, but he said, well, yeah, I try to. I would take walks and stuff, So not this identification or appreciation of the importance of intensity or how long the exercise session needs to be to garner those benefits that we know can be neuroprotective or lead to neuro recovery. Another key quote was this non-Hispanic individual who said, I kind of just make exercising in the morning my job. Instead of having to go to work, I exercise in some way, shape, or form, whether it's going to the gym or playing pickleball or even doing a kickboxing class online or at home in the morning. He says, this is my job. I value this. I put resources into it. This is what drives me and helps me to stick to my exercise. So I mentioned that the family can serve as a motivator, and that was a common theme. But the family can also serve as an inhibitor of exercise and physical activity due to that lack of knowledge that we mentioned in the previous slide. So a Hispanic individual said, it's very sad when one's own family does not understand what one needs. You need support, you need help. And I think we all have that problem with Parkinson's, that our own relatives, the family they do not believe that you are truly encountering something with your health. And they think you're doing these things to get attention. So my interpretation of that is that the symptoms can be highly variable in Parkinson's disease. When someone is in their on stage or off stage of their medication, their functional ability and movement can be highly variable, as well as if they drive their attention to their movement, you can see a big difference in their presentation. So there's a misinterpretation by family and friends that might be leading to them thinking that they're just looking for attention and this isn't real. So lack of education for the family can be an inhibitor. Additionally, another person reported, my grandsons call me to make sure I'm not doing any yard work, to make sure I'm not doing anything heavy. So in the attempt to protect their loved ones, they are actually inhibiting exercise and physical activity in the management of Parkinson's disease instead of facilitating exercise and the use of physical activity. And then finally, one was that an individual indicated, my kids try to motivate me a lot, right? That's that facilitator of exercise. But then this person says, I don't want to go out. I don't want to slow them down. I don't want to be a burden. So this integration of the family being both a motivator and an inhibitor of exercise and physical activity. So this leads me to my research question, given that background. Is a peer partner training program and a peer-supported mobile health physical activity intervention feasible in Latinx people with Parkinson's disease? Can we create an intervention that is created by Hispanic individuals, that is implemented by a bilingual, bicultural research team with bilingual and bicultural interventions and content? Does that make it more approachable, where the family is involved and where they can be interacting with other people from a similar cultural and linguistic background to help them engage and really use exercise in the management of their disease process? So my aims are to culturally adapt and determine the feasibility of the peer partner training program. So that peer partner training program that I previously presented, we're adapting that training program as well as the actual intervention where the peers are connected. So I also want to determine the feasibility of this peer-supported digital health physical activity intervention that I've named Apoyo y Poder para Personas con Parkinson's, which means support and power for people with Parkinson's, app for short. And we're looking at the acceptability, the appropriateness, the feasibility, cultural relevance via both self-reported surveys and qualitative interviews. And then I hope to also address this exploratory aim to determine the effects of this intervention on the primary outcome being physical activity. I will be looking at it both in a self-reported physical activity using the physical activity scale for the elderly, as well as an objectively measured physical activity using an actigraph, a research-grade activity monitor. I will also be looking at potential mediators and moderators of this effect. And this brings me to my conceptual model. So for this intervention, the peers will be connected and together they will create an action plan and their independent physical activity goals. This will hopefully drive autonomy. The individuals will be educated using those educational videos that I'll show you an example of in just a second here, so that they can learn about Parkinson's disease exercise and how to support each other, as well as receiving feedback through the Fitbit, so the commercially available activity tracker that they will have access to and will use. They will be receiving feedback on how they're doing with their goals, and this will help to drive competence. And then finally, developing that social support on a one-on-one level with their peer. So they will be able to have one-on-one meetings, as I previously mentioned in the other intervention, and they will also be able to have one-on-one interaction using the Fitbit app, where they'll see each other's accumulated physical activity. We're bringing in another level of social support in this intervention, where individuals will also be engaging in a Fitbit community, where everyone who is involved in the study, consented in the study, will be able to interact with each other and support to provide that additional level of encouragement, social support. Hey, I went for a walk today, or great job, keep up the good work, I'm moving towards my goal, at the group level through the Fitbit community, as well as through our once-a-week exercise class that we will be running for people with Parkinson's disease. That will be a bilingual class. We will run the class in both Spanish and English, and we will be integrating Latin music and Latin dance and creating more of a joyful, fun, positive, engaging environment that is appropriate to this culture. And then finally, all of our educational materials and opportunities, we're encouraging family support and integration. Although in this iteration of the study, we are not consenting the family members and we are not tracking the family members for their outcomes, we are encouraging family involvement. And in order to be involved in this study, you do have to identify a close friend or family member who's 18 years or above, who will support you through this intervention. So you'll see in the second column here, these are what I believe will be the mediators of motivation for physical activity. These are those core components of the self-determination theory that will then ultimately drive the primary outcome, which is physical activity, as measured by the APTA graph, that research-grade activity monitor, as well as collecting data on self-reported physical activity. Potential moderators of this effect will be depression and apathy. So we will be collecting information on depression and apathy, both at the beginning and at the end of this intervention. I will, in the near future, be applying for an NIH K23 award training grant. And in that iteration, I hope to take what I learned from my Pepper Center project and run a randomized control trial using this intervention, where some in the intervention group, they will be having this additional level of peer support, while in the control group, they will not have this enhanced social support. And in the K23 award, I hope to look at some additional secondary outcomes related to disease progression, functional mobility, and quality of life. So a little bit more specifically on this study design, we will be recruiting 20 Hispanic individuals with Parkinson's disease, and they will all be educated in how to be a good peer support or a peer partner. We are not having that hierarchical model that we had in the previous iteration due to feedback from that previous study. So everyone will receive virtual asynchronous education as well as virtual synchronous education. This intervention will be completely virtual, completely remote, so that we're able to recruit across the whole country. So a part of this virtual asynchronous education is that individuals will have access to short videos on the key components that we're trying to educate individuals on. So what is Parkinson's disease? What is the best exercise for people with Parkinson's disease? What is a SMART goal? What is active listening? And so we are creating all of this content in both Spanish and English and making this available to the individual themselves, as well as their family members, to become educated about the disease process and the role that exercise can play. So here is our English version so that you all can be exposed to what this will look like. We have created this at an 8th grade reading level, so it's accessible to the patient as well as their family members, as well as potentially a teenager who is their grandchild, who is really integrated in their care and present in their life. So it gives the basics. In this example, this is the one about what is the best type of exercise. We really break down the different types of exercise that are critical components and that are directed by a recent clinical practice guideline for the key components of exercise in the management of Parkinson's disease. And we lay out how will this help you to help drive the salience for why they should be using exercise to help manage their Parkinson's disease. So at the individual level, individuals will become educated through those videos, as well as in-person synchronous video time that we will have to consolidate their learning through those videos. And then the individuals will be matched up according to self-identified gender. They will have, everyone will be given a Fitbit, as well as having that once a week meeting. We learned from the other iteration, people did not like chatting on the phone. They wanted to be able to see each other. So we will be having virtual meetings now, especially since everyone is very familiar with Zoom, so that they will have that one-on-one peer supporting connection with their peer partner. But then they will also, as I mentioned, have this group level, this additional level of peer support and social support by engaging with everyone who is in the study through this Fitbit community. And then through that once a week exercise class that will be available in Spanish and in English, will be run by our bilingual, bicultural research staff. And then we finally are encouraging all of our participants to share all this knowledge with their family and significant others in their lives. So in terms of my timeline, recruitment is starting imminently. I have my IRB approval. We have all the recruitment material out there. I'm hoping this is not going to be a huge barrier, and we'll be able to get those 20 Hispanic individuals excited and interested in participating in this intervention. I plan to run the intervention this summer, and if need be, we will run 2 versions of it, one in the summer and then one in the fall. And then I'm really looking forward to learning through my mentorship through the Pepper Center about data analysis, not only at the individual level, but at the dyadic level, as well as using multi-level modeling to help me understand these various concentric circles and levels of social support that we are implementing in this intervention. So I'd like to acknowledge the UConn Center on Aging and the Pepper Center and all of the amazing mentors that I've had to bring me here to you today, as well as the research assistants and students who are working in my lab. And with that, I will pause for questions and discussion. Thank you all so much for your attention.
Thank you so much. Jeff, you want to start it off?
Yes, let me see if I can, sorry, I'm going on an iPad here. So can you hear me okay, Mike?
Yep.
Okay, perfect. So thank you so much. Great talk. And that's the first time I've ever had anybody present a picture of my commute. So like that picture you had of Lakeshore
Yes.
Drive, like I bike that most days. I'm actually in San Francisco right now. But your work as a behavioral intervention, I'm curious about what you're doing to see what potential enrollees' acceptance of the intervention is. And so like all of your work is throwing me back to a trial that that Kevin Volpe and I think it was Scott Halperin did with smoking cessation, where they showed that people who it's really hard to get people into these programs. In our traditional biomedical, randomized controlled trial model, we're looking for biological plausibility and trying to use RCTs to control for unmeasured confounding. But in fact, for a behavioral intervention, it's just as important as to who participates and how many people participate versus like, does this intervention work or not? So what are you doing to sort of look at the acceptability of even enrolling in the study,
Thank you so much for that question. And this is something that I have struggled with and continue to struggle with, because in some of my dissertation work at BU, I'm really interested in motivation, right? And I looked at constructs like apathy. And guess who participated in my study? The people who were highly motivated and non-apathetic. And so this is the problem. And so I was really looking at kind of unique ways to enroll and get people to even participate. I went to doctors' offices and would sit in the waiting room while they were waiting to meet with their neurologist to say, hey, can I chat with you about a research study? And I would often have participants, no. And it was like, that's the person who is likely the best person to participate in my study. He's lacking in the motivation to even engage. So I don't yet, Jeff, have the answer to this. I'm well aware of the problem that it creates when I'm trying to look at motivation. And yet the people who are participating are often those people who are already motivated, right? They often don't need it. And that's why that was some of the, in that earlier work that I mentioned in the sub-analyses, it was the people who were less active at the get-go who benefited the most from the intervention. Of course, right? But how do we get to those people? if you know that answer.
Yeah, I'm not sure I do. I mean, and
share.
this is like a recurring theme that, you know, for a whole host of even like not behavioral, but even medical services, like even in primary care, it's like the people who need it the most are the people who have been using it the least. And this is totally analogous to that too. And so I think, you know, staying, you know, looking upstream and being very careful about the very top of your enrollment flow diagram will be of intense interest going forward. But this is great work.
Yes, thank you so much for the question
Thank
and
you.
for your comments. Thank you.
Thanks.
Hello, Dr. Bradley. How are you?
Thank you so much for the great presentation.
Thank you.
You know, I was wondering, when you were showing how Hispanic populations had less knowledge of the benefit on of exercise on Parkinson's, did that correlate with other markers of health literacy? You know, is it you don't know about exercise, but you know about other aspects of your health, or is it just, or does it sort of correlate that with other markers of like low health literacy?
So that's right. So that's a great question. And we did not collect data on health literacy in these focus groups. We did collect data on education and socioeconomic status, and those were not different in this sample. So we can maybe extrapolate that because their educational level and their socioeconomic status level is similar, that might not be the explaining factor. But no, I did not specifically collect data on health literacy, but that is likely something that I could collect moving forward to help us inform. Hopefully we're improving health literacy. That's what we're hoping to get them to improve upon with this intervention, right? That they understand what PD is and how exercise can help them with this intervention. But that's a great question.
Yeah, just to that point, I think I put it in the chat, you know, to Sarah's question was, we have one of our doctoral students in clinical psychology that's interested in this in the same community, and it's more focused on preventing Alzheimer's disease and related dementias. And it's kind of like this idea that physical activity, you know, seems to correlate well to, you know, support heart health, yet it also has all these other benefits that don't immediately come to mind when you think about brain health or other aspects that it has a protective benefit or just to maintain function. So it's curious, like, does it make a difference if you just need to find your health promotion has to like kind of hook onto whatever they might naturally care about the most? But quick question I was going to like pivot to is Parkinson specifically. I thought I'm familiar. We've done work in the past quite a bit in kind of chronic disease self-management. I'm thinking of like the Stanford program, Kate Lorig's work, and I thought they made a Parkinson specific kind of you know, kind of amendment to their program to address you know, kind of physical activity amongst other aspects of it. And I couldn't remember if it was, I think I thought there's a lot of struggles in this area. Is this right, in terms of like getting Parkinson's specifically, you know, to optimize self-management? And I'm just curious if you know the literature is that, or how your intervention might, because it's also peer-to-peer, right?
Correct.
Correct. Work.
So yes, I can definitely speak to that. So now that we have this kind of robust literature that's informing us about the power of exercise in the management of Parkinson's disease, in the dominant culture, the word is out, and there are actually people who are at disease onset are really effectively using exercise in the management of their disease, and they're delaying the use of dopamine replacement medications because we know that there's this honeymoon phase or therapeutic window before the side effects become really interfering with their function and their mobility. And so it seems like some individuals from the dominant culture are really effectively engaging with exercise and physical activity as their primary means to control their symptoms and manage their disease. However, there are others, and unfortunately what we're finding in Hispanic and other minoritized populations is that there's this fatalistic perception of aging, right? That this is just what happens as we age. There's nothing that can be done about it. So yes, you know, I'm shaking. Yes, I'm moving slowly, but this is just me getting old. So I don't do anything about it. And so that is playing the double role of inhibiting use of exercise in the management of Parkinson's disease. Is there's just this perception of what happens as we age. So that's then not having people say, oh, well, I need to exercise more. That doesn't fit with their worldview and perception of what happens as we age. So yes, there is problem specific to Parkinson's disease as well as culture in the use of exercise with this group, but there are others who are really overcoming those barriers and are really being empowered to use exercise to help combat this disease effectively. Yes.
Dr. Fortitsky.
Yeah, so this gets back to Jeff's question in a way. I'm wondering if you really carefully document reasons for refusal, and really, you can develop themes around why people say no to you in the cohort, that you're interested in. Might shed some light on what Jeff asked about, and contribute to our lack of knowledge really about why people end up saying no, why they're not motivated, because refusers will give you reasons for not wanting to participate, and some of those reasons might have to do with motivation, others might do to misunderstanding of aging versus disease and things like that. So I think kind of a careful documentation of refusal reasons could help address some of those issues.
Yeah, that's a great idea, Rick. And I just recently met with the recruitment corps, and we're having our very specific recruitment plan. And I can for sure add that into the recruitment plan, that we will specifically document those refusals to be able to analyze what is going on with recruitment, which I'm hoping is going to go smoothly, but things don't always end up happening as planned. Yes.
Yeah, I'm laughing. We had a trial with promoting self-management in COPD, and one of our co-investigators on the meeting was like, well, you know what? We really want to understand who's participating and who's not. So maybe when people refuse a study, we then contact them to see if we can have them do like a 15-minute survey so we can understand why they didn't want to participate in the survey. And we go,
Right.
I think it's like,
Right.
You didn't want to be in our research, but could you be part of our research?
Right, exactly. And getting them to agree to that, right? There's that burden of now they have to go through, it might be 15-minute survey, but they have to go through a 15-minute consent process and a 15-minute demographic survey, and then it becomes more onerous for sure.
Yeah, I mean, I don't know if there's any other questions, but while we have a couple of minutes, and I know we have Dr. Andrew Russell on the Zoom as well, but like the notion that a lot of these patients may be saying no or may not be, maybe hesitant to enroll. I'm assuming with this patient population, you have a lot of behavioral health issues as well that kind of stymie the original participation to begin with, and so there's almost like a tiered approach or a step care approach to get them to ultimately this more intensive intervention.
Absolutely, yes, and that's why we're also it's often that the family members are the ones that are driving participation. And so I'm hoping that the family members can help us override some of those behavioral barriers. But then we do plan to track through just some basic screening tools, depression and apathy, using the PHQ-8 and the geriatric depression scale, as well as a Lilly apathy rating scale, both at baseline and at follow-up, to see if we're making changes with that or if that's a barrier to the effectiveness.
Okay.
Thanks for the shout out, Mike. This was a really great talk. I'm a psychologist here in our clinic, but I think, that may be like a direction for the future. Like I often will see patients that will describe feeling like a burden on others, when I'm like, well, if it was the other way around, how would you feel? Would you feel burdened? And most of the time people are like, no, I would want them to let me know. I would want to help them. And so it's almost like I could see, maybe you involving content of, reframing some of those common depressogenic sort of negative thoughts in a different way, or, helping people realize that this is that we're all on the same page here. We all want the same things, and let's try to be flexible to get, these patients feeling good, feeling empowered. So I just thought I think all of the work you're doing is super interesting, and I just really enjoyed your presentation.
Thank you, Dr. Russell. Yes. I would love to work together to help develop those reframing interventions, right? I can see that being another educational component for sure. Yes.
Sarah, I think we're at the hour.
I think so. That was a really great talk. Thanks again.
Thank you so much. I appreciate all of your questions and feedback and discussion, and look forward to meeting some of you next week at the OAIC meeting in Virginia.
Great. I will look for you. Thank you so
Okay,
much.
great to
Friday.
meet
Thanks
you.
again.
Thank you for having me. Thank you.